Hopefully everybody can hear me. It's a good afternoon from all of us organizing the webinar for you today. I think some of you may have followed us over the whole series of things, and some of you may be completely new to the whole process. So what I will do is quickly say, so my name's Chris Hendricks, and I work together with the International Gaucher Alliance, and we've got multiple other partners as well, and Northwest University. And together we have a program which is led to many different diagnoses and things in this area of the world. But what the focus is on today is the event we've got around Gaucher disease, where we actually focus on what we call the neurological phenotype, or what people used to call type 3 disease previously. And this is the third one in the series. And for those who may not know, all of these recordings are available. You can find them on YouTube, and Vesna will put the link and things for us in there that people can get it afterwards as well again. So it's always good. You can look at the previous two. And basically it's been a build up over the last few sessions. So we started off with basic pathology, what is the disease, and then we went into more, how do we support patients, how do we do it, and we focused on more on the medical things. And then we look really hard at the feedback we received. And we got the sense that a lot of you felt that although you are learning a lot more, you don't feel comfortable and you don't think this is possible in Africa. So we thought this time around, we're going to change it. And we're actually going to get some of our African colleagues that we've worked with to share their stories, that firstly, you can see it is possible and absolutely it can happen. So it is these impetus which will be there. And then we've got Derralynn, which will again bring us the adult side of the things. And Aimee, which will join us also as well, and talk about the pediatric implications and focus a little bit more on the pediatric science and some of the other softer elements. But I will say it again, but I want to give a taster. So the next session, the final one in our series of 4, we're planning that to be an interactive session. And the whole idea is what we want is we basically want to that time give you some tools. We want to give you some tools and things that you could use that makes life easier for you, looking at these and finding these patients and managing them. So look forward to that session. The dates and all the information will be shared as usual again, but we will have a look at your feedback. And I will stop talking now because I think it's much, much better that we start getting into what we're all here today, which is our success stories. And for me, it's a great pleasure to welcome some of the people I've known for quite a few years now. It's a project which made quite a few years ago. I think we're edging close up to 10 years ago. We met the first time, Kandi. So Kandi is from Tanzania, and I'm going to let her introduce herself and then share with us her success stories, which is really nice for you all to see.
Okay, thank you. Yeah, my name is Kandi Catherine Muze. I'm a pediatric endocrinologist from Tanzania. And yes, we've known Professor Chris Hendricks. I think it was 2018 or 2017, where there was a beginning of series of trainings for us pediatric endocrinologists and other pediatricians, which enabled us to be comfortable with diagnosing inborn errors of metabolism, including this lysosomal storage disease. And we realized that it's possible, especially when you put your minds to it, it's possible to treat and care these children. I just outline of my presentation is just a short presentation, so it doesn't have very long outline. For those who have been here maybe for the first time, I'll just say Gaucher disease is a rare inherited lysosomal storage that results in a deficiency or low levels of beta-glucocerebrosidase enzyme, which is due to the mutation in GBA gene. It's really under-recognized in sub-Saharan Africa. Though we are now getting into it, we're improving. And for many years, giving an example of Tanzania, this patient will be misdiagnosed as chronic anemia malignancies, sickle cell with hypersplenism, or any other chronic infections. It was very rare to say like Gaucher disease as a first diagnosis. So for those few who were suspected to have Gaucher disease, because we didn't have a means of confirming them, they were only maybe treated for splenectomy. That was our option by then. But now in less than a decade, we have seen some progress, especially in awareness, diagnosis, and care of these children. So regarding our type of Gaucher disease, we have three main types, but these are overlapping of symptoms and signs. So sometimes it's very difficult to give a clear cut that this is type 2 now you are going to type 3, and we usually say it's a continuum of diseases. Type 1, which is most common, like in our setup, I think type 1 is the one which we see most often, and it affects liver, spleen, blood, and bones. Type 2 and 3 are those types which we say neuronopathic because it affects the brain. And it has been said that type 3 is the most common in Africa, but in our setup, I think we still see type 1, maybe because we think we are maybe underdiagnosing type 3, and this type 2 may be neuronopathic. But in my practice, since we've started diagnosing them, I think still type 1 is most common. As we said, there's a continuum of conditions from asymptomatic type 1. And when you start seeing neurological involvement, we're now thinking of type 3. And we have severe forms in infant, and it starts very early, which is type 2. But in between here, there's a lot of symptoms. But when you talk of type 3, it's usually said there's a very significant symptoms, which is eye involvement, like horizontal gaze pulse, where people, the child can have difficulty in turning on horizontal sides. But in my situation, I've not seen this, maybe because in children, maybe it's difficult, but it has been documented that eye movement is a very significant symptoms and signs you can look for to say this is type 3 or other neuronopathic Gaucher. Challenge in Tanzania before those 2018, before we knew how to diagnose these children, we had limited awareness among frontline clinicians. So there was delay of misdiagnosis and lack of local diagnostic facilities for enzyme assays and genetic testing. We didn't have any specific disease treatment by then, and many children, of course, experienced, apart from delayed diagnosis, there were a lot of irreversible complications, maybe an early death, and poor quality of life. So I'll share you a case where we've seen a child who was 10 months old by then. He was admitted at the age of 6 months with history of progressive abdominal distension and fever for 1 week. He was palmar pallor, is pale, but there was no lymphadenopathy, and there was a huge hepatosplenomegaly. And while he was referred to us, of course, the first thing we usually do, we think of, oh, it's sickle cell. But there was no evidence of sickle cell. As you can see, the HbS was 0%. And the full blood picture was more of pancytopenia. The viral titers, usually we screen for viral titers, those common EBV virus, hepatitis, HIV, toxo-rubella, all were negative. And peripheral blood smear confirmed that there were features suggestive of pancytopenia, but the marrow was reactive after bone marrow aspiration. So while in the ward, there was worsening of the condition, even hematological status were really getting worse with gum bleeding now and petechiae because of low platelets. And this necessitated multiple blood transfusion, including platelet concentrate, packed RBCs, and the progressive spleen enlargement up to 20 centimeters. So you remember this was a young baby. So 20 centimeters was almost touching a superior iliac crest. And there was severe difficulty in breathing, weight loss, and abdominal pain. So after some time, we thought maybe we should do splenectomy because really there was huge splenomegaly. And by then there was no means of testing. So the mother, but later on, got the private lab, which it was expensive, but rather they volunteered to take the sample to India by then. So Gaucher's disease, Gaucher disease was confirmed by genetic. And while we were waiting for approval to start enzyme replacement therapy, because this is donor funded and we have to ask for approval for the child to be involved in the program. He died 2 weeks post-discharge after status epilepticus. He had severe seizures. But before that, there was no seizures or no significant neurological symptoms. So we didn't think much, maybe it's type 2 or type 3, but rather we thought maybe it's type 1. But after history of seizures, multiple seizures, but then he didn't make it. He passed away. And we received these results with the presence of homozygous genetic, which were suggestive of type 3. And the comment was, although there was no neurological signs, but type 3 Gaucher diseases, most of such patients are known to progress later on to develop neuropathic. It's not necessary maybe for the first time you see the child has already have neurological signs. So some of the patients, they will present later on, like our patient, that was seizures was the late occurrence. But for treatment, we know that the gold standard treatment remains enzyme replacement therapy, though it does not cross blood-brain barrier, but should be given to improve the conditions like hematological or visceral signs and the quality of life. Of course, we see children who are receiving them, the spleen, the liver, they are getting better as they receive the drug. In Tanzania, we are using velaglucerase alpha. The recommended dose is 30 to 60 units per kilogram every 2 weeks. But in our setup, because a lot of children are coming in a very late stage, so we are using them 60 units per kilogram. But when you read other literature, they will say 30 to 60, others even 15 units per kilogram. So the approach, especially when you are dealing with type 3 neuronopathic, is usually multidisciplinary because you need a neurologist, you need hematologists. For us also, we are involved in endocrinologists, but nutritionists and other disciplinary. So it's usually in a cooperation of other disciplinary approach. So other options which are not available in our country, but you can read about them, is substrate reduction therapy, which is oral drug, and it's said to cross the blood-brain barrier. I don't know, Chris, maybe you comment later in the other expert. It said you can use it alone or in combination. And we have pharmacological chaperone therapy, like Ambroxol, and as for guanine. This one, Ambroxol, is also one of mucolytic agent. I think it's used in cough syrups. So other options, of course, include gene therapy. So in Tanzania, from 2018 to 2025, I like to show these slides because every time I present, I show this to even myself, I see the milestone where we came from. So now we have 68 patients so far. When I first presented this slide, we were only like 40. So now we've screened 68 children, and positive were 28. And for now, we are waiting result for 2 patients who we've already confirmed by enzyme test and biomarkers, which are very increased. So we are just waiting for confirmation of genetic. Unfortunately, sometimes it takes a turnaround time. It's still very long. So for those positive patients, the ones who are on enzyme replacement therapy are 16. And we had 11 deaths. And in fact, when I tried to see the mortality of these children who are 11, a lot of them, quite a number of them were below 2 years. So I think we were dealing with either type 2 or type 3, but maybe we didn't realize before. Because of those who we diagnose below 2 years, usually they have poor prognosis. So the success story, we are having now a partnership with international experts and donation and support programs, which now we proud say that we now transform suspicion into confirmation, and confirmation now we are head off with the care of these children. And we have increased the clinician awareness. We do a lot of case discussion, teaching grounds, regional collaborations. We have improved the access to dried blood spot enzyme testing. I tried to show it. This one is very easy to transfer. And from this, you can get your biomarkers, your levels of enzymes, and genetic confirmation. And through international collaboration, this has been possible. Of course, our future priority, we think we advocate for research in African phenotype. And only today we've received that one of our publication for Africa has been accepted for publication, which was a good gift in this year. So in conclusion, Gaucher disease in Tanzania is no longer a diagnosis of exclusion, but though we say rare, but no longer invisible. It's obvious we can diagnose them. And success stories show what is possible when awareness, diagnosis, and partnership align. With continued collaboration, I think children with Gaucher disease type 3 can live longer, healthier, and more meaningful lives. So thank you. Just to finish up with a map of Tanzania showing distribution of patients with Gaucher disease, they receive treatment in various other centers. Not necessarily all of them to come to Muhimbili National Hospital. No, we send the drugs to where they are. So it's possible to receive this treatment after every 2 weeks, because we make the drugs nearer to them than coming to our hospital. Thank you.
Thank you, Kandi, and what a wonderful success story. I'm so proud every time I see that, and we need to celebrate it. But please, if you've got any questions, start putting them in the chat. We'll have a Q&A right at the end. So please start putting your questions in the chat box, and we'll get to all of them, and we can have a discussion at the end when everybody's done their thing, so we don't take the thunder away from somebody who's going to speak. And so next, I'm going to move on to one of our newest group that's actually joined our Africa Roadmap project. I see we've got online here Dr. Oumer Harun. If I remember correctly, he also was from our Botswana event, which I quickly checked was 2017. I think it's the first time we met as well. But again, wonderful to see you online. And again, we've now started the process to actually get samples in a more regular way from Ethiopia into our testing program. So I wanted him to share his case as well. And again, to show you that even as somebody which has come on later to the official process, it hasn't stopped him from achieving something wonderful for a patient. So over to you.
My name is Dr. Oumer Harun, and I am an assistant professor of pediatrics and child health in Haramaya University, and I practice in Youthfana Comprehensive Specialized Hospital, which is located in Harar, Ethiopia, which is the eastern part of Ethiopia. And today, I am not here to discuss the case as an expert of rare disease, but as a companion who worked along the family, along their journey of discovering the cause of the problem for the family. And this is the first case of Gaucher to be diagnosed with genetic and biochemical testing in Ethiopia. There was no prior report of confirmed Gaucher disease in Ethiopia. And I will try to present my case. I have two siblings. I will try to contrast the outcomes of the same genetic disease, which they have the same genetic mutation, but the outcome is very different, just based on the early detection and treatment access for the two patients. So let me start by introducing the index case. He was born on August 23, 2022, and he presented at the age of 8 months with progressive abdominal swelling and failure to thrive. The initial symptoms started at the age of 8 months, and he presented with gradual abdominal swelling and poor weight gain. And at the 9 months, he lost his ability to sit, which is a developmental regression. And he started to have chronic cough and night sweating. And then we just thought this could be TB, and he was started on empirical anti-TB treatment for 4 months. Because TB is very endemic in our setup. He was not responding, and because we misdiagnosed him, at the time the X-ray and gene expert was also normal, and he didn't have any contact history. Otherwise, he didn't have a history of jaundice, no rash, no bleeding tendency until it was very late, and there was no history of malabsorption, or he didn't have prior history of malaria, and no exposure to visceral leishmania, which is common in Ethiopia. On physical examination, his weight was 6.1, and the length was 61 centimeter. As we can see, they are very much affected, and it shows they are severe underweight and severely stunted. And his smoke was 8 centimeters. It is severe acute malnutrition. On general appearance, he appeared ill, and he was distressed when abdomen was palpated, not because of pain, but because of the enlargement. He couldn't breathe well. And on abdominal examination, it was grossly distended, and they have massive hepatosplenomegaly, and the liver was 13 centimeter, spleen was 16 centimeter, which is massive. Otherwise, there was no sign of fluid collection. This is our child. As we can see, the abdomen is very grossly distended, and there is a visible ribs. He is very emaciated, despite the big belly. On other part of the examination, there is no petechial rash, no ecchymosis, he has no icterus, and there is no edema. And on laboratory, we did the complete blood count. He have pancytopenia. Hemoglobin was 5.8. He's severely anemic, and the white blood cell is 3,200, showing leukopenia. Platelet was also affected, so all lines are affected. We did the peripheral smear, thinking this could be leukemia, or other hematologic malignancy, but there was no blast, no parasite was shown. And on coagulation profile, there was mild coagulopathy, the bilirubin, and other thing doesn't suggest any kind of hemolytic disease, which can present with organomegaly and the CBC the affected CBC. So it's not hemolytic, and albumin was 2.8, which is low, which could be due to chronic illness or which could be due to severe acute malnutrition. And for the common cause like infectious, we did viral markers. They were negative, and CMV were also negative. Gene expert was done twice, it was negative, and malaria was excluded. So this is definitely not infectious, which is common in our setup. So at this point, also, if it is not infectious, not malignancy, it was very puzzling for us because this kind of we never experienced it before. And within the abdominal ultrasound, which shows massive hepatomegaly and splenomegaly, and there was also multiple splenic infraction. As you can see, it was a massive liver and spleen. and the chest X-ray was normal. And at the age of 12 months, his condition he's getting the mass was very enlarging, and he became transfusion dependent for severe anemia and thrombocytopenia. He had repeated hospital admission also for infection. So we referred him to for hematologist or gastroenterologic evaluation to the central part of Ethiopia, which is to Addis. So they did the bone marrow, and initially it was inconclusive, and a repeat showed Gaucher cell. So now we get the direction, the Gaucher. So if it is not definitive and it is non-specific, because it could be seen with other disease entities. So the family at this point were advised to go abroad, but it's not possible for financial reason. They can't go abroad, so they returned home with a dying child who has no hope. And they came and visit us multiple times. They don't have any hope, so we try to look for any humanitarian organization through the social media, and I contacted Tanya, and so the collaboration started through the social media, and we somehow get access to the DBS testing. So DBS was collected at the age of 1 year and 8 months, almost 20. He was 20 months old. At that time, the enzyme assay showed it was severely deficient, and the marker of the Gaucher is very elevated, and the genetic testing show hemocytes for this particular mutation, which is associated usually with severe phenotype. So we get the final diagnosis of Gaucher disease type 3, because you have developmental regression as well. So we got the diagnosis, but there is no medication. So this is very important. As you can see, it's very critical. So we again try to look for a donation for enzyme replacement therapy for our patient. And while we processing the logistics was there, so while we communicating through the humanitarian program, his condition deteriorated rapidly with splenomegaly, couldn't breathe well, and he started to have bleeding diastasis, and he died at the age of 22 months, just 2 months after diagnosis. And after just 4 months, his sister was born. After he passed away, after 4 months, the sister was born, and she was currently 1 year and 4 months. The mother was grieving for the son she lost, and she was very curious, and she consciously examined the abdomen of the newborn. Almost she palpated every day, and she noted the spleen was palpable, and she came for medical visit immediately. So when we examine her weight is 6.2, and length was 61 centimeter. As you can see, she has also some kind of failures to thrive, and the spleen was just 2 centimeters below right costal margin, and there was a slight pallor. Otherwise, there is no bruising or petechiae, and she has some kind of strabismus on eye examination, no bone lesions. And we didn't look for any other differential because of the family history, and she has typical manifestations. So we just sent the enzyme testing, and the enzyme activity is nil. So the biomarker was very high, and the same mutation is found. So now we know how to access, and so we contacted through the humanitarian aid, and she was started on enzyme replacement therapy. And currently she is taking glucocerebrosidase alpha at the recommended dose of 16 international units per kg every 2 weeks. She's very close to the hospital, so this is not a big burden to have a follow-up. Without treatment, she would have the same fate as her brother because it is fatal. It's fatal, and she could have the same prognosis with the brother. So the getting enzyme, as you can see, the time is very short. It didn't take long to diagnose her and to start her on medication. And after she's almost taking this glucocerebrosidase for 1.5 years now, and her anthropometry is improving, but still she's malnourished, and her weight is also increasing. The liver is not palpable. There is some just enlargement with her age. Otherwise, the blood count is also normal, and she has no drug reaction. So we are monitoring her, and with CBC and growth is being monitored every 3 months, and every 6 months we do the scanning, and her echo is normal. And this is the therapeutic goal and my patient progress. So we achieved with the anemia, we achieved the goal, and thrombocytopenia is also we achieved the goal. The spleen and liver, we achieved it. And with the growth, we tried to look for other possible causes, like we did thyroid function test. It was not affected. We still incriminating to the Gaucher. And neurological, strabismus was not changed. She still have it. And she also developed some kind of seizure. She's on phenobarbital. Otherwise, she's still living and happily smiling with the family. This was the recent chest X-ray we took, and there is some kind of lung involvement as well. And I'm consulting with Professor Christian, and he's very helpful because he's very helpful in guiding through the management of my patient, and I really want to thank him. And still she has some kind of problem, but we will, I think, overcome some of the problems. She's on phenobarbital. Currently, she don't have seizure, and she has some kind of developmental delay and failure to thrive, but still she's living. During the last time, we also screened the family of the child. So both parents were found to be heterozygous carrier with the same mutation. The mother was diagnosed at the age of 24. Father was 31 years old when the diagnosis. We told them about the risk of recurrence. So the risk is like 25% chance of having an affected child and 50% chance of being an unaffected carrier. So the family is aware. And the barrier we face is like there is no, because we didn't have, there was lack of awareness of Gaucher disease, and we didn't suspect her initially to be Gaucher. And there was also inaccessible. There was, the confirmatory test was inaccessible, and even the way we acquired the medication was somehow very logistically. The medication was not listed in Ethiopian Food and Medicine Control Authority, so it took us time. But now, even my colleague from other center, he had the same patient. I think it's going well because he know who to contact, and that's the success in our case. And to increase the awareness, also we are doing a case report with Professor Christian, and also I would like to thank him on the help he given me. Thank you very much. This is all I have.
Wonderful, thank you. And I've got so much to say, but I would leave it until we get to the Q&A. I just want to say, I just want to comment before I forget. It's wonderful that a mother can find this spleen much better than most doctors in a high-income country. But let's not get into the controversies. So I think next, let's move on to Derralynn, which is now going to take us into the adult presentations and some of the supporting things that we could do for our patients. So Derralynn, it's over to you.
Hello everybody. I'm really pleased to have been invited to talk to you today about the bone manifestations in neuronopathic Gaucher disease and potential therapies including joint replacement. These are my disclosures. Bone-related health issues are common in patients with Gaucher disease. This includes both neuronopathic and non-neuronopathic Gaucher. In this US series, you can see that bone pain, osteopenia and osteonecrosis are all very common. There can also be fractures and osteoarthritis, which can go on to lead to functional difficulties, requirement for hip replacement and walking aids, for example. And so these are Gaucher manifestations which can lead to particular problems for patients and really reduce their quality of life. We see significant bone manifestations in neuronopathic Gaucher disease, and that is particularly for Gaucher disease type 3. The progressive systemic disease is accompanied by neurological manifestations, of course, but nearly all the patients have some radiological evidence of skeletal involvement. There's 3 disease processes ongoing here. We see focal osteonecrosis and osteosclerosis. This in turn can lead to local processes such as thinning, bone deformity, and more generalized osteopenia and osteoporosis. The incidence of avascular necrosis is around about 12 to 34%. This is a schema which attempts to try to divide up the various pathological processes in Gaucher-related bone disease, so that we see those primary changes such as changes in cytokine expression, alteration of vascularity, and local increase of pressure due to the Gaucher cells, going on to lead to changes such as osteopenia and lytic lesions due to the changes on individual cells such as osteoclasts and osteoblasts. The secondary changes then include bone infarcts, bone necrosis, and acute bone crises, leading finally to tertiary changes such as osteosclerosis, osteoarthritis, and joint collapse. And it's these changes which go on to lead to pain and disabling manifestations. Out of interest, I've shown you some cells that we have cultured in our laboratory which illustrate some of the changes that we see in patients with Gaucher disease. We can culture osteoclasts from peripheral blood, and you can see that on the right here the cells from Gaucher patients are larger and have more nuclei than those on the left from a control healthy individual. And also those osteoclasts create much larger pits on bone surface. They're more motile, more aggressive in the degradation of bone. This goes some way to explaining some of the changes that we see that can lead to changes in remodeling and also thinning of bones. But we also see changes in osteoblast formation. So when we apply various lipids to osteoblast cultures, we can see that the osteoblasts don't grow as well as those from healthy individuals. And this has also been described for others in various animal models of Gaucher disease. And this suggests that there is an imbalance of osteoclast and osteoblast activity, leading to some of these specific bone manifestations that we see in Gaucher disease. This included the Oumer-Harun deformity, which is characteristic flaring of the distal femur and proximal tibia and abnormal bone remodelling. We also see avascular necrosis. This is a major irreversible complication. Once it's happened, we cannot reverse this. Bone crises, there is painful episodes from infarction and hemorrhaging, and it can mimic osteomyelitis. In some patients, we see pathological fractures and also osteolytic lesions. All of these go together to have a real impact on health-related quality of life. And in this study, you can see that this was most impacted in the pain domain in patients with bone disease compared to those who didn't have bone manifestations. There are particular manifestations that we see in Gaucher disease type 3 or neuronopathic Gaucher disease, and this includes scoliosis and kyphosis, again having a real impact on quality of life. Also spine and chest wall deformities, progressive kyphoscoliosis, vertebral collapse along the thoracolumbar spine, and this often involves multiple vertebrae. There can be indications for a surgical approach to the kyphoscoliosis, including chronic pain, lower extremity weakness, but it is something which requires real consideration before going ahead with that. It requires posterior instrumentation, anterior decompression, and regular follow-up. Enzyme replacement therapy has a role in Gaucher-related bone disease, and it does lead to a reduction in bone crises and improvements in bone pain. As you know, it can reverse the hematological presentations in Gaucher disease, and when started early can prevent some of the skeletal manifestations. In young patients, it can result in improvements in growth and bone mineral density. But there are limitations, mainly due to the timing of starting of enzyme replacement therapy after a diagnosis or after some of the irreversible complications such as avascular necrosis have occurred. And there is some evidence that in some patients AVN can still occur despite enzyme replacement therapy. So early initiation and regular musculoskeletal surveillance is essential for helping our patients with Gaucher-related bone disease. Enzyme replacement therapy has beneficial effects not only on the osseous manifestations of Gaucher disease, but also in the bone marrow. And here you can see a patient who'd had enzyme replacement therapy for 4 years, and you can see changes in the bone marrow and the changes we see on the MRI. This occurs more quickly when patients have been treated with the higher dose or the approved dose than those who were treated at lower doses of enzyme replacement therapy. And so we see that whilst some lower doses of enzyme will have similar effects over time with things like hematological manifestations, and eventually patients will achieve the same response. It may take longer. In bone disease, because of the irreversibility of some of the manifestations if they occur, I think if wherever we can, it's important to give optimal treatment according to the approved doses. So there is a persistent risk in Gaucher disease type 3 of AVN and of other manifestations. And so we look for adjunctive therapies such as bisphosphonates, which can slow bone resorption by inhibiting osteoclasts. and other therapies which have also been tried, such as teriparatide and hematopoietic stem cell transplantation, which can stabilise bone disease in some cases when, as usual, given in the infantile time. And just to note, currently SRT is not approved in neuronopathic Gaucher disease. People have also used total hip arthroplasty in Gaucher disease, the indications being AVM of the femoral head leading to osteoarthritis, resulting in pain and reduction in mobility. Historically, there have been concerns about infection and poor bone matrix due to the Gaucher cell formation, but in fact, other series more recently have shown good outcomes of hip arthroplasty in Gaucher disease. We need to think about the perioperative considerations, such as optimizing hemoglobin, platelets, platelet function, and thinking about anesthetic techniques and recovery room stays. With enzyme replacement therapy, improvements have occurred and complications being relatively low. And primary total hip arthroplasties show enhanced quality of life, low radiographic loosening, and a low level of implant selection. There's an impact on the selection, including thinking about the sort of ceramic on ceramic bearing surfaces and the outcomes they might give. And some good reviews have been recently written about this. So overall, hip replacement is a viable treatment option for patients with Gaucher disease, particularly in patients who might be getting a little older. So importantly, skeletal disease remains a significant complication in neuronopathic Gaucher disease and a major cause of morbidity and a major cause of reduced quality of life. Enzyme replacement therapy improves the systemic and hematological manifestations. It has some limitations, particularly when treatment is started later after irreversible manifestations. We should think about adjunctive therapies such as bisphosphonates and also surgery, including total hip replacement. So thank you all for your attention, and as always, I'm very happy to answer any questions. Thank you.
Good. Thank you very much, Derralynn. And I said we'll take all those questions at the end, but please put them in the chat so long. Start thinking about them. And I'm going to hand over to Aimee next, who's going to be talking on the paediatric side and a little bit of what support and help we can offer as well, and looking yet again more on the practical things which you can do even if you don't have enzyme replacement therapy.
And so again, this is really nice, this session actually, because we've kind of moved across lots of the different aspects of neuronopathic Gaucher disease, from the tiny kiddies and some really sick kiddies to thinking about more of the systemic disease. And we're going to just have a little think, and I've just put a few slides together to help us think about thinking, so cognition, social communication, behavior, mental health, and we're going to touch on a little bit about seizures as well. So this is maybe slightly more conceptual, but it's just to help you think maybe in a slightly different way about the patients that you're looking after. And for these tiny tots that you've got at the moment that we've heard about, some of these issues may become more significant as you look after them, and some of the older patients, some of the topics I'm going to talk about might resonate a little bit more. And so I just thought we would talk kind of a little bit more broadly about terminology and concepts, because we often talk about mental health, and I think sometimes what each of us think we're talking about maybe not be the same as what somebody else is talking about. And we use a variety of terminologies, and all of these different concepts all affect one another, which is why I've put them in this nice little round circle for us to think about. So I guess we often, when we're thinking about children, we talk about their behavior and the challenges we have around behavior. And so that might be that they are hyperactive, It might be that there is some aggression or frustration manifesting in that child, and that could be part of their disease process. It could be a reflection of the kind of box next to it, the social communication difficulties, or what some of us might call autism. But it also could be a mental health problem. So children who are anxious or scared or sad sometimes will have difficult behaviours, and that's how they express those behaviours. But also a child who has what we call a social communication difficulty might not be able to express how they're feeling or even comprehend how they're feeling, and therefore that manifests as a difficult behaviour. And so sometimes these things which you think might sit in one area actually are part of another area. And then we think about what some people will call cognition, some people will call intellectual ability, some people will talk about their DQ. So if you're reading papers, you will hear about DQ. So that's your developmental quotient. This is about learning, this is about memory. So these are your kind of intelligence tests, your ability to learn, your ability to think. And so learning difficulties, which we sometimes see with children with neuronopathic Gaucher disease, sometimes overlap with children who have a social communication difficulty, so maybe autism or ADHD or a hyperactivity disorder. And obviously those difficulties might manifest behaviorally, and they may have an impact on mood, or mood might impact on those abilities. So we've got this whole world of different types of challenge, part of your mental health, your thinking health, your interaction with the world. And I think it's really important because I think we all have an idea in our head of what autism is. And it is a huge, that's why it's an autism spectrum disorder, because it's a huge spectrum of difficulties. And I think it's really worth going away and just reading a little bit about what we mean when we talk about autism. I think a lot of our children and our young adults with neuronopathic Gaucher disease have features of autism. So maybe some rigid behaviors, some difficulty communicating with others. So they might have speech delay, they may be nonverbal, they may not share their interests with other people, they may not make good eye contact, but their interaction with the social world is different to somebody who is neurotypical. And then their difficulties with those interactions means that their behaviour might be seen as being difficult behaviour, when in fact they just have no other way of expressing what they're experiencing. So I think it's really important as paediatricians, as physicians, that we have an understanding. We're not going to be experts. We are not psychiatrists or psychologists. We're not educational health professionals, but we need to have some understanding of that, because it affects how we interact with our families, and it affects how we counsel our families as well. And when we think about all of these things, it becomes a little bit easier to see how everything in our environment therefore impacts on our social communication, impacts on our behavior, impacts on our mental health, and impacts on our learning. So how we teach children, how we learn in education, we might have to modify that learning to enable us to meet the needs of those patients. The way that you're resourced as an individual. Now, whether that's the healthcare resources that you have access to, or whether that's the financial resources you have in your home to enable you to access the supports that you need to engage with the world, to learn, to develop, to have the space and the resources you need, is impacted by those financial resources that you have. What your family is like, how busy is your family, how able are they to support you and to provide you with a kind of directed and supportive environment. What is your sleep like? What is your the other aspects of your disease like, and how does that therefore impact on each of these domains? So when we're thinking about mental health, when we're thinking about intellectual function, when we're thinking about behavior, we have to think really holistically and think about how where that patient is in the world and in their world, and what that looks like, and what are the factors there that we could potentially modify. So we're going to think a little bit about neuronopathic Gaucher within that kind of context. And so this really is a thinking exercise. It's just trying to imagine a bit more holistically. Okay, we have a disease, we know a little bit about it. There are some limitations on what we can do about neuronopathic Gaucher disease. We can't fix all of the disease at the moment. And so what are the other things, what are the wraparound things that we can do to optimize the care and the outcomes for our patients? And so I thought first, just thinking a little bit about the brain pathology. We don't actually know huge amounts about the pathology. We've kind of very crudely presumed that we get this toxic accumulation of substrate in the brain. We know some of the regions which are primarily affected, and one of the key regions is the cerebellum. And I think many of us, when we think if, as neurologists and as non-neurologists, we think cerebellum, ataxia, movement disorders. We all remember those things that we learn in medical school about dysarthria, ataxia, rigidity. All of these motor symptoms of an impact on the cerebellum. And I've shown you these scans here are from a patient with neuronopathic Gaucher disease, and I've seen scans similar to this before, and they get calcification across the cerebellum just to really demonstrate that there is disease in the cerebellum that is progressive over time. And while we do see some of these motor symptoms, we forget the relationship between the cerebellum and other brain functions. And there are a whole series of investigations looking at the relationship between dysfunction of the cerebellum and autism. But there are also other syndromes that we see. So if you've had a brain tumor which affects the cerebellum, we sometimes see children that become mute acutely, post-operatively, and that generally improves over time. But it tells you that there's something to do with language there that's affected by interrupting the cerebellar function. And again, we see this cerebellar cognitive affective syndrome. I've just put one of the papers there, which is really about highlighting that the cerebellum does a lot more than just stop making you shaky and making you ataxic. So that it is responsible for your executive function. So that's your planning ability. And that might be something that you recognize in some of your patients, particularly your older patients. Their ability to do multi-step planning is difficult. Linguistic processing, impacting on your social communication, your ability to understand information, process it, and then relay information linguistically, so with language. Spatial cognition, and we see that really commonly when we do these intellectual function tests and we look at what a patient can actually draw, and their spatial recognition, that interaction of understanding space in time is challenged, and affect regulation. So this is about mood. This is about how we respond to our external environment. So we know that any disease impact that is significant with the cerebellum can have a lot of these more cognitive, intellectual, sort of social communication challenges as a result of it. So that just gives you a bit of context as to why we would see some of these features in the context of neuronopathic Gaucher disease. We also see seizures, and we've heard some examples of that today. And while seizures, we tend to say only prolonged seizures are the ones that can be directly damaging to the brain. And actually, really the challenge with prolonged seizures is that the longer a seizure goes on, the harder it is to stop. And that's why we always want to stop a seizure early in its progression, rather than being too worried about sort of hypoxic brain injury as a result of a seizure, which is of course possible. But seizures also impact patients and affect all of these other aspects of disease. So seizures, recurrent seizures, can affect learning. If you've got continuous background slowing, that's likely to make it harder for a young person to learn and to retain information. And then when we add in some of the anti-seizure medicines, some of those can be very sedating. You can have toxicity from those, which again will affect your ability to learn and retain information. They can affect mood. And I've put a link there just so that you could have it's a very simple link there, just looking at some of the common anti-seizure medicines and the impact they can have on mood and behavior. Again, it's always very patient specific. So although we know that sometimes these cause impacts on behavior and mood, you kind of have to trial it and see with each individual patient. We know that seizures in themselves have a stigma, and so that can actually cause patients to withdraw from society, become more introverted because they feel anxious about going out. They don't want to have a seizure in front of other people. The seizures can be interpreted as something non-medical, and that's really distressing for a lot of patients and for families as well. The actual seizures themselves, so I have some patients who they stop eating a day or so before their seizures start, and they become more withdrawn, they become quiet, and then they'll go and have a cluster of seizures, and then they're very fatigued afterwards. So that disruption, that could be 3 or 4 days where their routine is entirely disrupted, and they're unwell, and that kind of knocks you off. And so that impacts both mood, interaction, confidence, and is represented by your behavior as well. And then we also have to think about how some of these anti-seizure medicines can interact with other medicines that we might be using. So while the seizures themselves might not be the cause of your mental health challenges or your cognitive challenges or your social communication challenges, everything that goes around them or as a consequence of them will have an impact. We also have to think about what else we see as the common features of neuronopathic Gaucher disease. So we've all heard, and we heard in some of the previous sessions, about the saccadic eye movement defect. In itself, your inability to jump your eyes from place to place probably isn't that, doesn't have a huge impact on function. When it gets really severe, it can do, and people will reposition their head. They'll find that they're more prone to trip up on, they've got to step over a curb or something, that they're more likely to have trips and falls, in part because of their eye movements. They're limited in what they can do. So they may be young adults, might not be able to learn to drive because they would have to move their head to be able to respond appropriately when driving. We know that many of our patients have hearing deficits, and often those are undiagnosed, which has a big impact on learning as well. So they may not be able to hear effectively in the world around them. And we've already mentioned the ataxia, so they may feel off balance. So you've got a hearing, a vision, and a balance difficulty with many patients. And sometimes those could be almost subclinical. So unless you go looking for them, you might not really detect them. But actually, the functional impact, particularly when combined, can be really significant and can have a big impact on an individual patient. And I often use this slide of this busy train station in the UK, and I found this picture today, which I hope represents a typical play area in Africa. And I share this because I try to think, if I was that patient who couldn't look around quickly and easily, if I can't necessarily hear everything acutely, I've got some difficulties with my forward planning because of my executive function challenges, and I can get off balance quite easily, so I can trip up. If you put me in one of these environments that is busy, that is noisy, that I've got a task to do. So for a child, that might be, I want to be able to play with the other children. I don't want to stand out. I want to be able to engage. I want to be able to climb this climbing frame just like everybody else. That suddenly becomes really intimidating, which for a patient or a person that doesn't have those challenges, it's not intimidating. You just go and jump on and you get involved. If I'm a young person or an adult and I go to a busy train station, a busy bus station, I need to navigate to the correct place, and I need to be able to get on that train. I need to have bought my ticket. There's a series of steps there that I need to plan for, but then I have to navigate through this noisy, busy environment. That suddenly becomes really intimidating. Something that should seem really simple becomes really intimidating. It's an unpredictable, overwhelming environment. And so for many people, they would say, actually, I'm just not going to do that. I'll stay at home instead. And so they withdraw. And that reduces their confidence, it affects their mood, and it affects their independence, their autonomy over what they choose to do. And so you can suddenly see how something which is a disease problem becomes a social problem, becomes a mental health problem, and it becomes this kind of almost perpetuating cycle of difficulty. So I just think that's important for us to try and imagine ourselves with some of those challenges. And then we remember that our patients with neuronopathic Gaucher disease have all of these same systemic Gaucher disease symptoms, which may actually be worse, and they may actually be more intense, and there may be more of them. So they may have, as we've seen with some of the presentations today, bone disease, lung disease, liver disease. They may not be growing well, so they may be nutritionally deficient. We see a lot of our patients tell us about pain. And that may be pain from bones, it may be pain from elsewhere, it may be pain from the kyphosis. But pain has a huge impact. None of us need to try to imagine. We've all had pain at some point in our lives, and pain has a huge impact on how we want, whether we want to be around other people, how we feel about ourselves, what our mood is like. Similarly, fatigue, having a chronic disease which is active in your body makes you very fatigued. You might be incredibly anemic. And so that fatigue, add on the fatigue of having just had a seizure, again, huge impact on your mood. And pain might affect your sleep, which therefore makes you more fatigued. And I've mentioned constipation here because we never talk about it in Gaucher disease. And I was looking at a patient's spinal scan just the other day, and I thought, gosh, again, every single scan I look at of a spine, and I can see how constipated our NGD patients are. And we've never looked at it, we've never considered it. We know that we see it in Parkinson's disease. I'm almost certain there is an association. But don't forget things like constipation. Because if you've ever been constipated or you've looked after a patient with really bad constipation, they're miserable. They are tired, they are bloated, they're in discomfort, and they feel fed up. That's something that we can do something about. And they often don't report it to you, so you have to go looking. But I would say just don't forget some of our basic medicine that we can do things about. And then if you put all of that stuff together and you've got a patient, particularly in a place where hardly anybody knows about Gaucher disease, you've got a long-term rare disease, probably progressive, that's going to get worse, that a lot of people don't know anything about. So there's a lot of uncertainty. There's a lot of questioning who you are and what this means for you. And there's a lack of understanding, maybe within your social network, your family network, and now also within your medical network. And so it's so important that you acknowledge that you guys are now the experts, and you need to empower yourself to say, because you've all just shown us your case series and your case reports, you are experts in this disease. And I really want you to have confidence to know that you are experts and that you can share your expertise with your patients. And that doesn't mean that you have to have a curative treatment. We don't have the curative treatments. All of our patients are very different. And so you use this network that you are building to ensure that you are thinking, you're asking questions, but you're supporting and you're giving your patients that confidence that they're not on their own with this, because those are really important aspects of your care. So although this isn't necessarily what you think we maybe do as doctors, that we give medicines, we do tests, we give a treatment. And when we don't have that's not where the story stops. There are other things that we can do. So the things that I would really want you to think about is this really holistic assessment. Set expectations and set goals with your patients. So what we have to accept, we can't fix everything. We can't. At the moment, we don't have a therapy which stops the progression of the neuronopathic aspects of Gaucher disease, but there can be goals that we can try to achieve. We can offer that understanding to our patients and to their families, and we can offer them education, which is really valuable. And you've shown us, having a mum that's able to identify a spleen, you are educating your patients and your families. You're already doing this. And so I just really want to encourage you to continue to doing that. And then think about, well, what other supports, what resources, how can we empower people to help themselves and to help their relatives? So think about the social network, think about what's available there, think about the family, think about education. If you've possibly got access to psychology, then use it. But think about school and education, and you know, for your patient, should the goal be to get specific educational qualifications? Maybe not. Maybe the goal is actually life skills and independence. And can we teach this young person to count? Can we teach this young person how to make a meal, how to go to the shop, you know, to function and to get some independence, which gives them confidence and therefore equates to better quality of life and fewer mental health problems. So these are just thoughts and ideas, and I appreciate that sometimes we just want to be told, give this medicine, do this test, give this medicine, and everything will be better. But the reality is as it is, and it's actually no different in many ways. Where I work to where you work, I've got more tests that I can access, and I have clearer path to ERT, but that's probably it right now. And so we have to think about everything else that we can do to care for our patients. So I hope that is helpful, or at least thought-provoking.
Thank you so much, Aimee. And I think it's really important that we continue to remember there's so much we can do. And while people are getting ready to put their questions in the chat, I just want to highlight another case report from Africa just to show where it is. So we had a patient with Gaucher disease in Rwanda, and typical teenager, he wanted to come off his enzyme replacement therapy because believing he's got no benefit from it. And what we were able to do is, together with the IGA, we were able to put him in contact with a buddy, somebody else in another country. And I think Vesna can help me. The buddy, I think, was in Australia. And they connected from Australia to Rwanda and started talking to a buddy. And that helped him through this crisis where he was struggling. So that's the non-human things we sometimes forget. And if you've got that open relationship with your patients, they would actually tell you, listen, I don't think this works or whatever. And once you've got that open communication, you can start thinking not, oh, you've got it wrong, but actually what is underneath it, like you've explained to us, and start working through and how can we help them and keep them going. So that was just a thought on that. And we are going to open up to the questions. One of the questions actually ties in what I wanted to say as well. Somebody asked, where is enzyme available in Ethiopia? That actually ties in what I wanted to say and open up. So as some of you were a little bit later may not have heard, so our publication on the pilot study in sub-Saharan Africa has been published today. It should be out relatively soon in Orphanet Journal, so which is a great achievement, the pilot project. But that set up what we call the Africa Roadmap. And everybody in the roadmap, and I encourage people to join the roadmap and share your details in there, because it helps us to find people in different countries and connect people who's got a specific interest and can help us to manage patients or know what to do. So that comes back, and that's very much linked firstly to being diagnosis and education. The education we did today, and there's another webinar to come, which I'll talk a little bit later, but that's coming still. But basically, we are linked to multiple charitable access programs. There are two which is specifically for Gaucher from two different companies. And when there are patients which are acutely unwell, we usually say the information needs to go to IGA, because they've got direct access to that program very quickly. These are usually for these young children which are very sick and for which we need treatment very quickly. For everybody else, there is a cycle of 6 monthly applications. Now, the current round of applications is just closed. It closed on the 2nd of January, and patients will be allocated to treatment by the committee. And if anybody's got questions, I can talk about that as well. The committee will meet on the 2nd of February, and they will decide on who are the patients who will benefit the most from treatment. We do believe that, unfortunately, it's a scarce resource. We can't give it to anyone. So the committee decides who is going to be the most beneficial to get treatment. And there are multiple clinical experts, the patient organization, and all the ethicists on that group to try and make sure we make the right decision for patients to get treatment. So that's where you get treatment from, and there's a formal process, and there are only specific countries which has been approved. We're slowly working our way through finding different ways. Now, where the charitable access is not available, we're starting to work on something which is called early access programs. You will hear about more of them across this year, and I'm trying to get people to give us a lecture on early access programs. That means you can't have access to the drug because there's some restrictions or rules, but there's different ways to do early access, and that will be coming later in the year. But to add on to, and I always want to, just before I take the next questions, if there's any, just to update you on some wonderful news. You know, we had the event at the end of October to add additional countries onto our roadmap network for testing. Now, we have a patient from Namibia, which has already been diagnosed. I've just had an SMS message from the people in Zambia. They've diagnosed 4 patients since that meeting with Gaucher disease. The first patient started treatment today at the first infusion. So it's just amazing to hear what you guys are achieving. So I just want to say, don't give up. It's possible and it's happening, and keep doing it. And there's some really, really great opportunities going forward. And the African proverb, you know, how do you eat the elephant? Bit by bit. So we will get there. So I just want to touch on something which Derralynn have said and which has come through. And I think it's just, and Derralynn, you can say what your view. My view is that, especially in the pediatric population, we know it's a scarce resource, but if at all possible, if you can treat your patients at the correct dosage, the maximum dose, which protects the bone system better, because your bone formation is most probably, I won't go into all the technicalities, but your bone formation was probably at its peak around 25 years of age. And don't call me ageist. That's what the science tend to say. So if you can get your bone health as perfect as possible for the first 25 years, you've got reserves to hang on to. So I encourage people to do the simple things. Get your enzyme up, look at your vitamin Ds, look at all the supportive things, and get them as good as you can for especially the kids, and then take it from there. Derralynn, if you're about, what is your views on those? Oh, you're on mute.
Sorry. Yes, I agree entirely. If it's possible, that would be the best thing to do. There's good evidence showing that for hematological parameters, lower doses get there in the end. It's just slower. But for bone, getting there slower risks something irreversible. So if you can give a dose that's closer to the optimal dose, the approved dose, that would be appropriate for bone disease.
Good, thank you. Chat. Well, I don't see any questions. I'll start talking about the next. Just that you know, we will confirm the date of the 4th and the final one in this series of the webinar. What will be helping is that we will be sharing some tools. We'll be looking at what practical tools can we give or make available to you that you could really get to know all the individual elements, and how can we support you better. And digital tools and things are becoming more and more valuable, so they will be there. And those are the most important things. Please look out, keep following out, look out for the Africa roadmap. Please follow us there. It's really important. And I see Chris Foster has just said, and I do agree, thank you. And the team at the university is helping us set up genetics. So that's also in the pipeline for this year. We're hoping to get genetics sorted, that we can actually get it done quicker, and we can get it done locally. And then the next challenge would be, can we get carrier testing? And I want to make the comment there, well done for Oumer's team there for getting the carrier status, because genetic testing and prenatal counseling is so important. But at the moment we don't have the facility, but that's something for the future. And it should be relatively cheaper, because you already know which affected gene is and the mutation. So it should be able to offer carrier testing and start looking at better options for our patients. So please keep that in mind. connect to us. And for those in Africa, make sure you join the Africa Roadmap Project and keep a lookout. And I'm going to leave to, I don't know if Kandi or Oumer want to say anything more before we kind of close the meeting for all of you. I don't want to keep you beyond the time. Good. Any final thoughts from everybody? Otherwise, we'll
I think
close.
I don't have.
Sorry.
Yeah, I just say that I don't think I have anything more to say, but I encourage all African countries to look for these children. I think they are there. We are just missing them.
Absolutely. And just for those who are not from Africa, just to remember that you sometimes may think, why are people doing that? TB and HIV are the chameleons in Africa, so they present with each and every way. So people test them first. And then we test for malaria on many, many patients, and sickle cell. Those are the things which comes in first. And then leishmaniasis. Those are the things which these guys will be the world experts, and they will be rare diseases for us. So if you ever have one of those patients, ask these guys. They will be able to help you. Thank you, everyone. Have a good evening, and see you on the 4th webinar.